Hello, and welcome to our NCD Academy panel discussion related to COVID-19. As the coronavirus continues to disrupt daily life across the globe, the American College of Cardiology and our partners at the NCD Alliance and World Heart Federation are bringing together experts from across the healthcare sector to discuss the varied impacts the pandemic has had on patients that we care for. Today, we will be discussing how non-communicable diseases have been and continue to be affected by COVID-19. My name is Gluckman, and I'm honored to be the moderator for today's discussion. I currently serve as Medical Director for the Center for Cardiovascular Analytics, Research, and Data Science at the Providence Heart Institute in Portland, Oregon, and also chair the American College of Cardiology's Solution Set Oversight Committee, a group dedicated to developing clinical policy and tools aimed at closing gaps in care. To get us started, it is my pleasure to introduce our esteemed panelists, Dr. Katie Berlacher and Dr. Simon Ray. I'd welcome both of you telling us a little bit about yourselves. Let's start first with Dr. Berlacher.
Hi, Ty. It's nice to see you. Thanks for having me. For everybody, my name's Katie Berlacher. I'm located in Pittsburgh, Pennsylvania at the University of Pittsburgh Medical Center. I'm the director of the fellowship training program here. I'm also the director of the Women's Heart Program, which is located just a block down from our main hospital here, where we have 11,000 deliveries there, and I see a lot of high-risk pregnancy and cardiac disease. Thanks for having me.
Thank you for being here. And Dr. Ray?
Good evening. It's early evening in the UK. I'm a cardiologist based at the University Hospitals in Manchester, at Wythenshawe Hospital. I'm also the president of the British Cardiovascular Society and co-lead of a national program that we have called Getting It Right First Time, which is around trying to abolish unwarranted variation in cardiovascular care in England.
Fantastic. I really want to thank both of you for taking time out of your busy schedules to participate. So in setting up the discussion today, I thought it may make sense to spend a few moments talking about the state of the state, and I'll do that briefly. As I think you both know, COVID-19 is an ongoing global pandemic caused by SARS-CoV-2, and as of today, there have been more than 23.5 million cases and 810,000 deaths attributed directly to the virus worldwide. And while these numbers alone are staggering, COVID-19 is also having an unprecedented effect on non-communicable diseases as well. As I think both of you know, and we're going to talk a lot about, hospitals have seen extraordinary decreases in emergency department visits and admissions for a wide range of acute conditions, cardiovascular and otherwise. And similarly, our face-to-face visits that we're used to in the outpatient setting are way, way down. And while the immediate effects are only starting to be appreciated, it is unlikely that we will really understand the full effect of this for many years. So I'm going to start out first by asking Dr. Berlacher, what does your hospital look like today? You're sort of straddling the Midwest and the East Coast, and we've seen parts in the States affected by an initial wave and beginning to see some case counts in certain places rising. Are emergency departments back up in terms of visits to where they were? Are admissions still down, or are they coming back up? And have things returned anywhere close to pre-pandemic states?
Good questions, Ty. We are lucky here in Pittsburgh, Pennsylvania. Now, we never had a huge surge, unlike some of the other cities in the States. We had a bump, and then a kind of another middle bump midsummer, and we are fortunately back down to our lower rates where we were in about April. And we're excited about that, given that most of our emergency room visits in our kind of core center city hospitals are close to back to where they were prior to pandemic. Our elective surgeries and some of our other routine procedures and testing are not quite there yet. And what we have kind of facing us in these next couple weeks to months is where I'm located, there are about 4 or 5 major universities where college students have come back. in various different protocols and policies, but waves of them are coming, and whether they're all starting in person or not. And so we are bracing ourselves at the moment for a potential increased wave. But right now, we're kind of back, and I'm on service this week. We are full speed ahead as our inpatient service is normal right now, and emergency room visits normal, but the rest of it a little bit lower.
Great, really helpful. Dr. Ray, we sometimes get a little American-centric, as we were talking about beforehand, and you in the UK preceded the wave that hit us. What do things look like on the ground for you, and is there variability in how it looked across the country as well?
Yeah, so we had a lot of variability with the way that COVID came into the country. So London was hit worst and was hit probably about a month ahead of most of the rest of the country. So it was a big peak in activity with COVID in March in London, to the point where there were hospitals which were very close to being overwhelmed. Capacity was extremely stretched, and that then percolated out over the rest of the country. Where I am in the Northwest, we were undoubtedly pretty busy, but we had spare capacity in terms of our intensive care beds, having expanded out that capability a lot. But we were probably, in my own institution, never more than 50-60% of our ITU potential full. And I think that was probably the same through most of the country. There were, again, other hotspots of heightened activity in the Midlands, for instance. Where we are now is really quite different. So in my own institution, we have very limited numbers of patients in with COVID. The demographic that we're seeing in terms of the current infections is quite different, in that it tends to be a younger population who are less sick. It's probably social spread rather than the situation back in March. And in terms of our non-COVID activity, admissions through our emergency accident emergency departments are pretty much back to where they would be for this time of year, about baseline. What we are seeing is still a reduction in our elective and semi-elective activity across a range of specialties. And there are a number of different reasons for that. Part of it may be presentation, and part of it just is in terms of the way we've had to change the organisation of the services to comply with social distancing and to limit access to some extent. And one of our main focuses at the moment is planning for what might happen in the autumn. Because we're anticipating, as I'm sure you are, that we may have second waves and then subsidiary bumps, as you say.
Yeah, I think those are all great points, and many of us are waiting for the other shoe to drop and hope it doesn't, in terms of either Dr. Berlacher, as you brought up, schools coming back and locations where we didn't have a big populace, but now we're bringing tens of thousands of people back. And the other is just the challenges of what the flu will look like this fall, other illnesses occurring that time of year, and really we don't know, which is a really great transition to say, in the midst of this, as both of you know, hospitals across the globe took really great lengths early into the pandemic. They saw what happened, I would argue, not only in China, but in particular in Italy and in Spain, and recognized that there were the reality that you could overwhelm hospital capacity, and hearing about tragic circumstances of limited ventilators and having to make tough ethical decisions about who got certain care and who didn't. So in that sense, many of the hospitals took efforts to flatten the curve and avoid being overwhelmed. And most commonly that took the form of people getting deferral of non-urgent testing and procedures, Dr. Ray, as you had outlined. In fact, the American College of Cardiology in late March noted that it was reasonable to consider deferring any test or procedure that was unlikely to directly impact clinical care or outcomes over the next several months. Little did we realize we'd be sitting here at this time of year still dealing with the challenges that we have. Also, many governmental agencies around the globe and public health organizations encouraged individuals to stay home whenever possible, primarily to avoid spread, but also getting the infection themselves. So Dr. Ray, maybe starting with you, is perhaps people who have stayed back. And as you've outlined, people not even necessarily coming in for elective procedures today. Is this an example of good intentions gone awry? Could we have done a better job in communicating? Is this a unplanned but nonetheless a misstep in mixed messaging to our patients?
So I think that's a very good question. It's actually quite a difficult question to give an answer to, because I think it's relatively easy to start thinking about this from the perspective of August. Whereas if you take a step back and look at what the sort of situation we're being presented with in February through to the middle of March this year, and there's no doubt that, as you say, for us in the UK, Northern Italy was really the point where we started to worry, and we were communicating at a professional level a lot with our colleagues in Italy, and the health service here in the UK was watching what was going on in Lombardy, to some extent in Spain, with considerable alarm, because in Northern Italy has a very well developed healthcare system. Comparatively, they got a lot of hospitals, they got a lot of ventilators, and we were clearly in a situation where we could potentially have been overwhelmed. And I think if you look, and I mentioned that London was hit relatively severely, and there were hospitals in London which came very close to being overwhelmed. And I mean, fortunately, we had sufficient planning to reinforce networks of hospitals in a way that was firstly quite impressive, and secondly has not really been achieved before. So I think it's not really fair to say that it was good intentions gone awry. I think it was probably, in retrospect, even now, appropriate planning for something that we really had no idea quite how was going to pan out. I think if you then look at it in the context of August 2020 and say, where could we have done better? I think there was an assumption that what happened in London would happen in the rest of the country. And I don't think that's an unreasonable assumption. But what it meant was that, say, in Manchester, we shut down activity before we probably really needed to shut down activity. And I think the build-up of activity, again, as the pandemic, or the first peak of the pandemic began to wane, has also been a little slower than it could otherwise have been. And I think one of the lessons which we're trying to incorporate into any second wave is that we will try to keep elective, semi-elective activity going on longer before it gets to the point where you have to start shutting down to accommodate for large numbers of sick COVID patients. And again, as a second peak wanes, we would be starting to get elective, semi-elective activity up running again more quickly. But I think it's hard to criticize the response back in March on the basis that none of us within living memory had ever been dealing with something of this magnitude before. And I think perhaps something we can talk about a little bit later, but there are clearly a lot of lessons to be learned from healthcare systems, even very well resourced healthcare systems in Northern Italy and the UK and the US, about how we might respond in future to similar threats, which I guess they're going to come sooner or later.
I think you bring up some phenomenal points. I live in Portland, Oregon, and we had seen the initial wave go through Seattle and had sort of that advanced time of knowing it, but didn't get hit nearly in the same way. Dr. Berlacher, I wondered if you're at a major medical center, you probably have a huge catchment area. And again, I'm trying to put a one size fits all on something that isn't a one size fits all. So, what was the community response in the broader Pittsburgh community? How did major medical centers perhaps accommodate it differently than smaller community hospitals in your environment?
Yeah, we put in a very unique place here at University of Pittsburgh Medical Center. We have over 42 hospitals at this point, and so our catch area goes almost all the way east to the eastern state of Pennsylvania and up to Ohio and down to West Virginia. So we are a lot, and we have very large institutions. So where I am is the center academic place where we do all the transplants and everything, and then much smaller kind of community type hospitals, and we shut everything down. And I think what Dr. Ray was saying is really important to remember is that, our intention in the medical community is very different than the impact. And we did not mean to impact the medical community in the way that it was. But because we had good intentions and it's because we had to, we didn't know any better, right? We had no idea what we were up against. And for really generations, we've never seen anything like this. So we had to do what we did so that we could, shut everything down and keep it as safe as possible. And then, and unfortunately, there were unintended consequences due to that. And I think, moving forward, as Dr. Ray was talking about lessons learned, and as we will probably get to in the future, I think what I wish we would have done is not necessarily not shut everything down, because I think we had to understand where each community was, but have a different message to our patients so that we say we out of safety for you and our providers and our system, we are going to shut these things down, but keep a running log of patients that need kind of sooner rather than later testing or procedures or whatnot, and have that messaging not just be like, we're shutting down and when you'll hear from us whenever, maybe it's 2 months, maybe it's 6, who knows, but maybe just have a little bit more of a detailed plan and a net for those patients, because I think what ended up happening is that we scared them. We scared a lot of people, and we were scared ourselves. So I'm not sure that we could have done it much differently, but maybe a moment of a couple big deep breaths to think about the messaging would have been better. I again don't think that we could have done it down, just like Dr. Ray was saying.
And I think, as you both highlight, we didn't have the luxury of time in our hands necessarily to make these decisions. So we did the best we could under the circumstance of something that is once in a generation, if that. Dr. Berlacher, as you pointed out, unfortunately, one of the unintended consequences has been delayed care. And so it's one thing to delay an elective procedure, a hip operation, somebody dealing with relatively stable problems. But this is even more pressing for time-sensitive conditions like heart attack and stroke. And we've seen this for other things, even kidney stones, people who've had respiratory infections not related to the pandemic. In realizing this, and again, I think hindsight's always 2020, but multiple professional societies, and we all know this best in the cardiovascular domain, but the American College of Cardiology, the American Heart Association, the European Society of Cardiology, they've all launched campaigns to make sure that patients know that hospitals are safe. They're the right place to go to seek medical attention overall. Dr. Berlacher, perhaps starting with you, at your own institution, how are you seeing your medical center communicate to the broad swath of patients that you normally care for to, again, double down and reinforce that point, regardless of whether it's for cardiovascular services or otherwise?
Good question. I think it's been multi-pronged, as it should be. Like I said, we are a big center and we have a lot of resources, so we're really lucky. One of the first things that we did, what was it, back in April even, or May, was our system came to a couple of the known kind of leaders in various different subspecialties and said, we're gonna make a video and put out a commercial. And they made, a 30-second commercial that said, we're here for you, we're open, please come in, with 6 of us doing a 5-second thing, and we put it on Twitter and on YouTube, and people are watching Netflix and they're watching they're on their computers now and on their phones all the time. So we really, it's to get the information and the news out to where people are already. So whether it's social media, whether it's the local newspaper, whether it's the local news, whether it's commercials, all of those places. And so we kind of peppered everything that we possibly could, and then also told patients to tell their friends, other people, to say, hey, we are here, please just tell everybody that you can keep coming in, we will make it as safe as possible. And really, while we initially messaged that nobody should come, stay home and shelter in place, those sorts of things, we have managed to come up with ways to make it safer so that you can still come in and get the care that you need while being kept safe. So that was really a multi-pronged approach to kind of try to go to where the people are already.
I think it's great. And Dr. Ray, you obviously in the UK are part of, as Dr. Berlacher spoke about, she's speaking about it from a health system perspective, but I wonder, is this also going on at a national level for the health system that exists in the UK, and has been an organized effort to really put out public service announcements to say, please go to your hospitals if you're having an acute medical illness, regardless of the etiology?
Yes, that's absolutely right. So again, we had a multi-pronged approach. So if I start with our own institution, so we're a tertiary stroke quaternary cardiac unit. We're serving an immediate population of around about 3.4 million. And we did exactly the same. We had a video made. We had our cath lab staff, our secretarial staff, we had administrators, we had clinicians, all doing little couple of second pieces of a message saying, look, we're here for you. Come in. You know, if you're unwell, we want you to come. We're making everything as safe as we possibly can. And so lots of individual institutions did that. Nationally, we had, and I should, just by way of a little bit of explanation, I've been talking a lot about the UK, but actually most of what I'm mentioning is specific to England, because our health system is slightly different in the devolved nations. So in England, there was strong messaging starting to come out of NHS England at a relatively early stage, as soon as we realised anecdotally that there was a big drop in acute presentations. And that the two things which were picked up first really were STEMI and stroke, because they're very tightly audited, and it was pretty clear that those numbers were falling rapidly. And so we had a national campaign via email, to some extent via social media, and I think that the question around that sort of national campaign is who you reach, and I think it's pretty good, quite effective at reaching clinicians, possibly rather less so at reaching patients and their relatives. And where I think we were more effective in doing that was involving patient groups, and particularly patient associations, so British Heart Foundation, Diabetes UK, the Stroke Association, for instance, who have a much better reach out into patient communities. And I think they were probably the most effective tool at getting that messaging out nationally. And we were, again, in retrospect, we could have probably been a week or two quicker off the mark had we anticipated it. But I think it's fair to say nobody had really anticipated quite what a big drop we were going to see in these acute presentations. Even with the benefit of having initial information, again, coming out of northern Italy, that was also the case there.
Yeah, I mean, again, no need to apologize for any of us in terms of the effort, but again, I don't think any of us had been through this. It does highlight, though, as we've all described already, what the fall may look like, about how we have consistent, non-cryptic, straightforward messages for our patients, and what are those multi-pronged approaches that we need to take. We've talked across the world about public service announcements and how to reach people about a specific focused area, but this is so much broader than that. I appreciate the points that both of you have highlighted. As you both know, as a result of people not coming in, a number of studies recently have highlighted rising in-hospital mortality rates, and this has been true for cardiac and non-cardiovascular disorders. And these are unrelated to people having concomitant SARS-CoV-2 infection. And I would say what's most distressing is what's not being reported. And there's recent data suggesting year over year total numbers of deaths that are occurring worldwide are up, suggesting above and beyond the pandemic and COVID-19 related deaths are people that have died at home out of fear or uncertainty, or the risks of going to the hospital or the clinic outweigh the potential risks that I may be facing, not knowing what perhaps is going on with them already. I gotta believe, because whether it's the economic impact, the fear, the infectious impact, the unifying theme for a lot of people that you talk to, patients I see in clinic that you both talk to, is fear. And it does raise the concern of the mental health impact that the pandemic has brought about. Dr. Ray, just perhaps starting with you, to what extent are you beginning to see the mental health impact being addressed? How are you perhaps in your communities, either on a local or national level, beginning to address the fears and concerns that people have, particularly in advance of the unknown, a second wave that may be coming without having a vaccine right now?
So I think this is a very good question, and it's an issue which I think initially has been underestimated in its importance, and I think we will find that the true importance of the mental health impact of COVID is going to play out over a number of years. And so I'll approach this by, I think there are a number of different levels of this. So that there's certainly the increased levels of anxiety that have been engendered in patients and people who see themselves as being at increased risk, rightly or wrongly, of contracting COVID. And clearly that has contributed to a lot of stress. I'm sure that it has contributed to people not attending hospital when they clearly should have done. And I think, as you've indicated, that's probably underlies some of the increase in out of hospital mortality that as we've certainly seen in the UK. It's now falling, but it was certainly there a couple of months ago. And I think there is also a huge residue of potential long-term mental health issues, particularly amongst people of school, high school, and college age groups whose education has been disrupted, whose adolescence, whose emergence to adulthood has been severely disrupted, whether or not they have significant health problems. So we are beginning to address this nationally, again through the National Health Service. But I think a lot of the really good work that's been going on has been done at local level by individual groups of clinicians, but also again patient groups have been incredibly supportive of individuals with cardiovascular conditions throughout this. And I think we've had a lot of feedback to suggest that it is that mutual support from patient groups that people have found most valuable. And I think that's something that has possibly again been a little bit underplayed in the past, and something that we need to capitalize on the future. And that it much as somebody may feel reassured. So I've been phoning a number of my patients who have expressed concerns about coming to hospital to try and talk through the realities of the balance of risk and benefit with them. But I think, and I hope they've derived reassurance from that, but I think we shouldn't underestimate the reassurance that people get from talking to peers with similar conditions. Now, clearly, that cuts both ways. You can get unrealistic levels of alarm engendered, but they can also provide very solid reassurance and mutual support in times of great stress for mental health.
And Dr. Berlacher, you and I are both part of large health systems. I'm one that spans multiple states, and we were equipped to handle mental health issues prior to the pandemic. Just curious to see your perspective on this as well.
Yeah, it's been a challenge. I think what Dr. Ray was saying is encouraging people to lean into their support systems and reach out to others for new support systems is really important. What I've also done, is utilize some of the things that have come online because of the pandemic, and because of it, there's been a lot more virtual resources that have become available. And so I've been trying to encourage my patients to use the things that either are newly developed or newly free, and trying to get them to use some of the apps that are out there, and doing kind of the basic things, the deep breathing exercises and meditative exercises, those sorts of things that sound a little hokey, and owning the fact that they sound hokey and saying that there's actually some utility in doing things that might feel a little silly at first, but in the long run may help you. And so I think it is really normalizing that and making sure that people feel heard in that fear and that we don't dismiss it. The other thing that I've noticed a lot, and this may be more in our country than in others, but there's been a lot of distrust of science and providers, and combating that and getting to the core of that, which I think a lot of times is fear too, but it's layered fear. And so having just patience with that, and sometimes it just means that you might have to have 2 virtual visits or a virtual visit, and then something with a provider of another sort to say this is okay, it's normal to feel this way, we are frustrated, and it manifests differently in everybody, and so just kind of reach out. So that to me has been the most important thing, is like what Dr. Ray was saying, is talking about it acknowledging it and talking about it, and then encouraging people to get help in whatever way they are comfortable getting help.
Yeah, and I love the idea of the virtual support group, which again cuts both ways, but I very much like that. Let's actually pivot and shift to the outpatient setting. And as was noted before, it's not just been on the acute care side, but we've seen face-to-face clinic visits saw a abrupt and marked decrease that really paralleled what we saw in hospitals in terms of ED visits and admissions. And one of the silver linings, and there are not a ton, but you relish in what you can from the pandemic, has been the shift to telehealth. And so, Dr. Berlacher, beyond the initial learning curve, I'd never done a telehealth visit in my entire life prior to the pandemic. And so how challenging beyond the initial learning curve has it been for you and your colleagues to incorporate it into your ambulatory practice?
Well, it's a learning curve, as you say. And I'm like you, it was available and kind of being developed in our system. And really, it took us all of 1 week for it to be pushed throughout the entire system and made available. So it kind of hastened us to get to where we wanted to be probably the end of this year, in early March. So we made it happen. The kind of the logistics of it, the technology was really the hard part. But really, as you got used to the technology and learned the interface in a software system, or loaded something new on your phone, so you had a backup, and learning the initial and then the backup and that sort of thing. But really, the harder part for me has been, how do I still bond with my patient, and how do I make sure that they feel comfortable telling me the things that they used to tell me when we were in person. I'm to be honest, I'm not sure I still have that down quite yet. I try to do the things. I am a physician that hugs, so it's probably good for me to be virtually away from people, because I would still want to hug my patients in person if they come in to see me. So it's better to have a barrier for me. But I still want to hear about their lives and smile and laugh with them, and to kind of do that over the video is a little weird at first. The other part that I've been challenged with is, when patients have the ability to take a phone call or a visit anywhere, you really go anywhere with your patients, truly in places that I never thought I would be with my patients. And so sometimes I'm like, wow, maybe there should be some boundaries in with our relationship. And so kind of struggling, figuring out like how close I want to be to my patients and they want to be to me. And it's a whole new world. So the tech and logistics aside, I think we can handle that, and I'll fumble with that time and time again, especially as the technology continues to evolve. We will all learn new tips and tricks, but for me, it's the relationship with the patient that is continuing to evolve in ways that were unexpected and welcome, and sometimes not so welcome. So I think that part of it is still just a steep learning curve. That's fun, but still steep.
And Dr. Ray, I'd welcome your thoughts about this. As cardiologists, I have family and friends who say, "Isn't your job to listen to their heart and lungs? How do you do your job?" And we all know that we see, and this is true across all specialties, there are some conditions that may be more amenable to a virtual or telehealth visit, and some that are more challenging. Maybe you could just share your experience with telehealth thus far, and the challenges that certain conditions may pose and others may be much easier.
Well, I was like you. I'd never done telehealth. Was complete novelty to me, and it was thrust on us in about a week. And we started with phone calls, and that's still mostly where we are in my own institution. We're swapping over slowly to video. And what I've noticed is, so as part of my practice, I do have a number of patients on long-term follow-up with cardiomyopathies, and so people I've built a relationship with over a number of years, and actually continuing that relationship with a phone call or video is easy, because you already understand, you've got a rapport with that patient, you have a mutually beneficial relationship and an understanding. I think it is a lot more difficult with new patients. And I think in terms of the specific groups that worry me, and I know worry my colleagues, are, for instance, so if I give you a couple of examples, and they would be the more complex patient with aortic stenosis, where you're trying to make a decision. Is this somebody who's going down a surgical route? Is this a TAVR route? Where the old-fashioned end of the bed eyeball test, I still find is really quite important. Similarly with more complex heart failure patients, and I know that my colleagues in congenital heart disease feel exactly the same way about some of the more complex patients with congenital disease, especially those who are in the process of transitioning from pediatric through into adult care. So I think it is these groups where there are multiple levels of complexity that are really quite difficult to sort out, at least in an initial consultation, even with video. So I suppose there are a couple of counters to that, and it's there clearly is a learning curve here, both on the behalf of the clinician and patients and relatives. And one of the things that has been commented on by a number of my colleagues is that for these complex patients, the fact that a virtual consultation allows you to have a lot of people in the virtual room, so you can get different specialists in the room, you can get family members in, you can get parents in. I mean, there are, as you say, some positives to be gained from all of this. And I think as we get better, I suspect that some of these boundaries will gradually dissolve away. But fundamentally, coming back to this point, it's the eyeball so-called end of the bed test. There are still going to be a hardcore of individuals who I think that's going to be essential for. And maybe just one other caveat to that. Of course, it is almost by definition, these are the people who are at highest risk of COVID, and often the people who least want to come to see you face-to-face in a hospital situation.
Yeah, all great points. And Dr. Berlacher, presuming it's here to stay, there is some excitement about telehealth. It does afford some flexibilities we otherwise don't have. What are the most promising aspects that you are looking forward to in incorporating telehealth as part of your care strategy long-term?
Good question. Yeah, I'm really excited about it because I think what I've been able to see and what Dr. Ray was talking about, the adult congenital patients are hard. And, those adult congenital specialists are few and far between. I think probably not only where you are, Dr. Ray, but also where anyone is. And just there's not a lot of the super subspecialized cardiologists or other subspecialists. And what telehealth offers is for us to be able to reach out hours away from systems to say, hey, I know it's hard for you to get here. And whether I like Dr. Ray was saying, I kind of virtually join an office visit with them 2 hours away from me. So there's 3 of us. Or if I just have the patient call me from their home, that's 3 hours away, that they wouldn't have otherwise driven to me. So even out of a pandemic time, they're just like, 2.5 hour drive into the city is not worth it. I don't want to do it. So I'm just not going to see you. So now they're like, well, but I could do a video with you. That would be okay. And while it might not be perfect, I mean, some of my high risk pregnant patients, I do want to hear their heart and listen. I will take a video visit if it's nothing versus seeing them over the video or talking to them on the phone. I will take that 100 times over not seeing them at all and just getting them when they come in for delivery or something like that. That to me is much more helpful. But what I worry about though is, telehealth is a double-edged sword, and we can reach out to some of those people who are in rural places, but it all is dependent upon them having access to either a phone or the internet. And so internet access more so than ever has become really important for healthcare. And that was something that I don't think we talked about when we were talking about excitedly in this. And I think the disparity in that care will just become a wider gap than it was even before.
And I would say in one of these similar recordings, we talked about disparities and inequities in care and the digital literacy, the access to broadband, which, again, you don't think about as often as probably we otherwise should, or maybe it's a self-reflection of me. I haven't thought about in the same degree. It opens up that it digs far deeper in terms of you're addressing one issue and only uncovering other issues that exist. I will say for our health system also, we've not been particularly consumer focused or focused on the patients. So for the patients who work from 8 to 5, Monday through Friday, it's not so convenient to get to take time off from work. So the flexibility perhaps of after hours, weekend visits affords a unique additional bit of flexibility that telehealth may afford. I wanted to pivot a little bit and to say, the World Health Organization has released some staggering data recently. They completed a survey of nearly 200 ministries of health worldwide, and they highlighted how much the pandemic has disrupted outpatient services. And I'm really talking about for chronic diseases. And as to be expected, as you would both imagine, hypertension, diabetes, asthma, and cancer were those that were most likely to be affected. But the impact to preventative services, when you look at cancer screening, mammography, colorectal screening, it is amazing how much it has been impacted by this overall. And although this may not be directly in your respective wheelhouses, how are you seeing your health systems, your hospitals begin to start talking about this? We've often been judged about the quality of care that we deliver in the ambulatory setting by meeting basic preventive standards, vaccinations, cancer screening. What are you hearing on the ground in that regard overall? Dr. Ray, any comments about that?
So I think you make a very important point there. This, again, wasn't something that was a particular focus 3-4 months ago, but is now becoming a very major focus, in that our entire national screening programs and surveillance programs have been completely disrupted. And whilst they are now opening up, they are not going anywhere near at the level that they were before. And so if you take, so my colleagues in gastroenterology would be putting very large numbers of scopes through in a day. So for surveillance colonoscopy in high-risk patients, for instance. Now, their ability to do that has been very substantially reduced because of social distancing. And it's hard to see how they're ever going to be, or at least so long as there is a risk from the continued threat from COVID, how that level of screening is ever going to get back up to where it was before. And so I think we need to, nationally, we need to be working out new ways of trying to increase access to screening. There's quite a bit of work going on in the UK about this. So, and in essence, most of this is are plans that were in place beforehand, which have now been accelerated by COVID. So to give you one example, there had been talk for a while about the idea of taking diagnostics out of secondary and tertiary care facilities and placing a lot more ability to do diagnostics for screening and surveillance in community-based settings, which would be, relatively speaking, easier to keep COVID-free. And all of that has been accelerated quite dramatically. Clearly, there are issues around funding, particularly in the current economic stresses. But I think what we've seen is really people are now trying to think of new ways of getting these screening and surveillance programs up and running. As far as cardiovascular goes, there are major concerns about hypertension. There are major concerns about screening for atrial fibrillation. And again, accelerated by COVID, we had published in 2019, we had a long-term plan for cardiovascular prevention as part of the overall health service long-term plan. And again, elements of that are being accelerated. We're trying to get a lot more patient-based, patients measuring their own blood pressure, recording their own blood pressure at home, sending them into their primary care or secondary care physician, looking at more effective ways of identifying atrial fibrillation in the primary care setting, for instance. The same with trying to make monitoring of blood sugars in at-risk patients easier to do in patients' own homes. So there are quite a lot of measures being introduced, but much of this is really work that was there already, which is just being accelerated. But there's no doubt we have, particularly for cancer, we've effectively got a 5-month hole in screening programs, which is a major concern.
Yeah, we have our work cut out for us. Dr. Berlacher, we're beginning to see clinics open back up, whether it's for a hug, whether it's to look from the end of the bag and get a better perspective overall. But the challenge that we have is many of the patients that see us that are seen in a lot of specialties are enriched with patients who have risk factors that when you look on the CDC or other international websites are the same risk factors that increase people for more severe manifestations of COVID. So in the same challenge under the acute care setting, how are we to convince our patients who have risk factors that portend higher risk were they to develop COVID to still come back and see us in the clinics, that clinics are safe?
Yeah, I mean, good question. Again, I think it's twofold. One is actually what are the measures that we are doing in the facilities with our providers and our staff and the people who are parking and the people at the front doors, all those, what are those measures? And then also the messaging, the messaging we talked about, so I'll kind of let that be, but I think that goes forward to the phone calls that, if your patient gets a reminder phone call to say, hey, this is, reminder, your office appointment with Dr. Berlacher is at 1 p.m., on Tuesday, the next couple of sentences should be, just to inform you, there will be a screener at the door. You will be mandated to wear a mask. Everybody that you see will also be wearing a mask to protect you. So just kind of doing that, other than just the specific kind of community-wide messaging that we talked about, individual messaging when there is a specific encounter that is planned, I think is really important. And then that the space is going to look different, right? So when you come in, there's going to be chairs that are separated. You can only ride the elevator with three other people at a time. Every person that you meet will have a mask on. And if they notice that your mask has slipped or you've taken it off to take a drink and forgot to put it back on, they will remind you to put it back on, those sorts of things. We are doing a lot of things in terms of how many people you can bring with you, or if you can bring anybody with you for your office appointments, and discussing that before they get in, so there is not, conflict or emotional reaction to those sorts of things. But I think it's many things that they have to do is not only prepping, but making sure that we are actually doing all those things, keeping everything clean, all of the staff wearing their masks and doing what they are supposed to do when patients come in. Not easy by any means, and it feels different. It feels different as a provider, and it for sure feels different as a patient coming in. And I think the best way to kind of talk to them is to prepare them for that.
I think well said, and I'll just give you my own experience. We had a footprint where the waiting room itself was not equipped to be pandemic ready, and so these were often small spaces with chairs one after another. Yeah. And it's not just on the patient-facing side, but how for our clinical staff, nurses, medical assistants, advanced practice providers, we often would have them one after another, and so creating a safe place for both sides of care delivery has posed a challenge. And on the one hand, there was excitement about telehealth in potentially reducing our footprint, the economics, if nothing else, of that. And then there's the other challenge of, if we're going to have face-to-face, you can't have both. And so how do you socially distance both groups? Which brings up a question maybe for Dr. Ray is, if both face-to-face and telehealth is here to stay, whether by phone or video, how are you prioritizing which patients get slotted for which type of visit? I will just tell you on our own, I wish it was being done in an extremely thoughtful way where you were analyzing each patient. It's much more still of delivery system convenience, acknowledge that there is some influence by care providers. But I would welcome, Dr. Ray, any thoughts about how you're addressing that challenge?
So that's a very good question. I think our situation is similar to what you described there, in that we don't have a uniform way of addressing this nationally, and to some extent it is influenced by the basic things like the geography of an institution and how easy it is to enable social distancing. And in relation to what Dr. Berlacher was just saying, we have completely redesigned our outpatient services such that it's one where you have to go around a certain route to get round it, and we managed to maintain social distancing. What we've been trying to do in terms of having a uniform approach, at least in our own institution, is that we have the means to triage all referrals in from primary care in a much more detailed way than we were able to before. So, I mean, this may sound very bizarre from your side of the Atlantic, but we were still getting significant numbers of paper-based referrals, and all of that has just suddenly stopped. Everything's electronic, which hooray! You know, I mean, we're in the 21st century finally. So we have the ability to triage those referrals. So we can, and one of the things that has been a positive out of this is I've probably had more phone calls to primary care physicians in the last 5 months than I have in the last 10 years. And so we're getting the referrals. We're now communicating back to those primary care physicians with much more immediacy than we would otherwise have been doing. So I've been picking up the phone. I've been talking to my primary care colleagues. We've been giving them advice, and we've been, to some extent, able to head off some of those referrals. And so I think what that does is it enables you to be able to select patients, broadly speaking, into three groups. One group who can just be dealt with advice, a second group who might need some investigations and maybe advice, and then the third group who actually need to come in. And whilst that is down, that triaging process is down to either individual clinicians or perhaps groups of clinicians, I think it does potentially lend itself to a reasonable degree of standardization, at least within an institution. And all of my colleagues in our own institution now are adopting this sort of strategy. It's a little bit, again, subspecialty specific, clearly. For some of the heart failure guys and adult congenital, as we've already described, it's a bit different. But I think the key point you make is around equity. It's trying to make sure that there is uniform decision making around this, and nobody is being disadvantaged. And I would estimate in our own practice at the moment, we are probably doing of new referrals somewhere between 60 and 70% are entirely virtual, and the remainder are face-to-face. So, which is just a huge shift from where we were.
Absolutely. I think you bring up phenomenal points. And, I hope at some point all of us look back on this and say there were some good efficiencies that came from a really horrific situation, but we are better off in our delivery of healthcare as a result. I know we're getting towards the end, but I want to round out two other final points. Is the economic impact of COVID-19 is staggering. And I'm not an economist, and it's not my background, but we know that we take care of patients who, unfortunately, the cost of receiving that healthcare is a big influence on what they get done. Many patients have lost their jobs. They're even more challenged than they were before to afford out-of-pocket costs for healthcare. And some are expecting that we may see reduced healthcare utilization that parallels the 2008 global financial crisis. Dr. Berlacher, are you already beginning to see this in your communities? And Dr. Ray, I'd welcome your thoughts about what's going on in the UK as well.
Yeah, it's really unfortunate at this point. We are starting to see people who are saying that they've lost their insurance now because they're unemployed. And the UK is different than America, and a lot of our insurance is tied to employment here. And so people are, even those that were maybe underinsured before, are certainly uninsured, or those who were uninsured and paying out of pocket don't even have that ability now. And so I've had patients, email me directly and to say, I can't come in for an office visit, or I can't schedule with you for an official visit. Would you mind just refilling my pills until I can see somebody? And so it's coming across in all different ways. And I think what we are charged with as a medical community and as cities and organizations is to figure out how we can offer some free care in this interim and this gap care. And so working with, community outreach services or neighborhoods and churches and whatnot, and giving them some of the resources that we can in this time, knowing that it's not going to be perfect and it's not going to be as good as it should be. But yeah, it certainly is already starting to trickle down to us that people are just even regular follow-up office visits are being skipped this time.
No, it's helpful. Dr. Ray, just the perspective from the UK in terms of the way healthcare is organized and the economic impact as it relates to access to care.
So obviously our system is different in the sense that around 95% of healthcare is delivered by the NHS, so effectively free at the point of delivery. It's not quite the same. People have to pay a bit for drugs. So we don't have the same issue, but we are seeing some impact. And the way I would characterize it is that people are, particularly people who've lost their jobs, where their job is in peril or whether they've been furloughed for a long period of time, are focusing all their energies on that aspect of their lives and are not really paying attention to their health. And it's almost, well, I've got other things to worry about at the moment. I really don't have time to come to the clinic because I'm not sure whether I'm going to have a job next week. And so maybe the pressures are a little bit different, but we are clearly seeing them. And I like you, I worry enormously about the long-term impact of this. I think the long-term mental health impacts are going to be considerable, and I suspect that the long-term physical health impacts will also be a substantial problem, not just in terms of people missing appointments because they feel it's not their highest priority, but simply the impact of the mental health, long-term mental health stresses on physical health are going to become apparent at some point.
You bring up a great point. And, as a comment, and I wish we had sufficient time to do this justice, I equally worry about the mental health of our providers, our clinicians who have had to adapt beyond the initial surge. And fingers crossed, we don't see what many of us worry about this fall with competing challenges of influenza. But this will have likely taken a toll across the board, whether it's our individuals that are frontline healthcare workers, whether it is trainees who, Dr. Berlacher, I know you spend an inordinate amount of your time with, in what their education and learning has been like with this. And then for all of us that have young children, grandchildren, what is going to be the impact of that loss of social connection and schooling? We will look back on this and have tremendous learnings and, disappointingly and sadly, not for the good in most circumstances overall. I wanted to give just a moment to each of you to sort of have any other final takeaways. This has been a potpourri of topics. It hasn't done justice to the full spectrum of non-communicable diseases, but it more so highlights the fact that COVID-19, while an infectious disease, to me, I can't think of another scenario where it's had such a staggering impact outside of its direct communicable effect overall. So, Dr. Berlacher, any final words?
Yeah, thanks, Dr. Gluckman. This has been really great. I just want to say a big thank you to you and the NCD Academy for doing this. I think it's really nice to be able to talk to people from around the world to see what is going on and what we can do together. The biggest thing that I've learned over the past few months is just that we are still learning. This is a big learning experience for all of us, and we are by no means done. And so I think a couple things are to be kind to each other, be kind to patients, be patient because this is hard and it's not going to get any easier. And then stay tuned, right? I mean, the easiest thing is to kind of turn off and to, especially as you're talking about all of the, as we all get mentally tired and worn down, the easiest thing is to turn off, right? And that's when you're at that point, that's the sign of burnout and get help. But really, all of us need to figure out a way to stay tuned. And that's both for patients and providers in some way, shape, or form. And so if you need help, reach out. And if others need help, reach out to them. But I think those are the kind of biggest tips for me. I'm constantly learning every single day, and this is by no means an exception to that.
That's great. And Dr. Ray?
Well, I would certainly endorse all of that. I think those are extremely well-made points. And I suppose my concern really is for the future and the future shape of healthcare, because the path of least resistance is to go back and do what you did before, because everybody's familiar with it. And I do worry that we may slip back into some old ways of practice, which would not be beneficial. And so what I'm hoping is that, at least within the context of the UK, we can take some of the positives that have come out of COVID and apply those for the future. So telehealth being one, but I think there are a lot of others, not least the fact that if we look as a nation, why the UK has had one of the highest rate of excess deaths worldwide. Now, we are a wealthy country with a well-organized healthcare system. Why should that be? And I think there is growing concern, the fact that we have an unhealthy population. I know it's the same true in elements of the US. We have a high frequencies of obesity, we have high frequencies of diabetes, metabolic syndrome, hypertension. And I think one of the lessons that I would really want to see coming out of this is that we nationally have to tackle it. Not just from the specifics of COVID and reducing risk for the future, but actually just in terms of population health. This is an absolute wake-up call as to what we should be doing. And I sincerely hope that will be a new focus, certainly in the UK, and I hope also in more widely in developed nations, because I think it's a common problem we have to address.
I think both your points resonated with me. Dr. Berlacher, we talk about lifelong learning, but this is learning on a weekly, if not daily basis, and the field keeps changing. And so it does require being on your game to learn on essentially a daily basis. And Dr. Ray, to your point, I've often said, shame on us if we go back to the way that things were. This really, we want as many silver linings to come of this. And if it means really transforming how we take care of patients at large in the population health space, I often am quoted as saying, because I do say it, my greatest joy in life would be putting myself out of business. And sadly, I don't see that happening in my lifetime, but hopefully for my kids or grandkids' lifetime, we can really make a significant inroads in many of these chronic preventable conditions that really are what keep our hospitals busy, but frankly shouldn't. So thank you to both of you. This has been an extraordinarily informative conversation for me, and I hope for hopefully both of you as well. I wanted to extend special thanks to both of our panelists, as well as all of you listening, for taking time to join. As there continues to be uncertainty on the timing of a vaccine, please stay safe, and thanks for all that you do. Thank you.